Hello and welcome to today's presentation. My name is Rich Payton and I will be your facilitator today. Today's review session is on health outcomes and population perspectives. So welcome to our presentation. So I'm a public health professional with interests in health literacy, racial and ethnic health disparities, and LGBT health needs. I came to public health after serving nearly 10 years in the military and federal government. Aside from my work in the field of public health, I've taught at community health worker course at Malcolm X College in Chicago. My education includes undergraduate studies at George Mason University and an MPH from UIC, where I focus on maternal and child health with a global health focus. I'm also a former board member of One Roof Chicago. I work as a public health consultant focusing on issues of queer equity, particularly focusing on POC. I currently work at Humana as the senior population health strategist. Enough about me, let's get started. All right, so why come to this? Why get certified? Why be here? Everyone you talk to will maybe give you a different answers, different thoughts. For me, it's a validation of my experience in education and push those things together and let me be showcase that. Also, it helps with a deeper understanding of the public health workforce, seeing what other people are doing, helping myself learn and going and asking questions of people in different fields so that I can break away from these silos. Also adds credibility as a public health professional. It's a personal accomplishment. I know that was for me, it was just a big personal accomplishment that I really wanted to do for myself. And it's a great resource for networking and within the community. There's a book club, there's LinkedIn, there's opportunities to, you know, once you've taken the exam and passed, becoming an item writer, and lots of other different opportunities that may be available. Okay, so the course is broken up, or the exam, excuse me, broken up across domains. Today we're going to be talking about health opportunities, excuse me, health outcomes and population perspectives, which is 10% of the total exam. Okay, so we're going to talk a little bit about what population health is. We're going to address social justice and health equity. We'll move on to some theoretical frameworks. We're going to hit several of them that are really important, but again, you want to make sure you are familiar with all of them. Then we'll go through some sample questions, and I'll give a few tips and tricks, and we'll move on. So the domain that we're discussing today in domain 10, again, 10% of the overall exam, we're going to apply a socio-ecological model to analyze population health issues and design needs and resource assessments that consider unique perspectives and group values and norms to address population health outcomes. Okay, I'm not going to read everything that's on each slide, but what this is saying is we're going to talk about health equity. We're going to talk about some theoretical frameworks that we have for behavior change and talk about just how this works as a public health professional and best practices. All right, so what is population health and how do we apply it across the workforce? When we think about being a public health practitioner, we think about the population, the communities that we're serving, right? And so, how do we do that? Each person is going to do this in a different way. If you're a statistician, if you are a community health worker, if you are a community engagement specialist, a director, we're all going to have different roles in how we help the community and help population health. So, the health status and health outcomes of whatever group we're talking about, right? So if I'm looking at the population or if I want to look at Black maternal mortality rates, right? That's going to be a population I would study. Um, I study a population that I would want to look into and find out whatever the research question is. So we'll be using we use an ecological systems approach, right? We don't just kind of go in willy-nilly. We really want to go in with an idea based on evidence-based practices and an idea of the CPH exam. You want to be able to know how to apply these theories, what they are, and how to work through them. We'll get to all that in a moment. Um, Also, a big part of population health is collaboration across different disciplines, right? Public health can sometimes be in silos. We want to make sure that we can cross that. We have cross-functional teams, the team of a CHW with a nurse and a MA and a provider and a case manager, all as part of one care team. We know that some of the things that we've been able to do successfully with population health is we've eradicated, eliminated diseases, been able to control outbreaks by focusing on particular populations, particular communities, and then just increase overall access to health services. And so, a few definitions here, and this is really important. Definitions are going to be a big part of the exam. It's one of the categories that we write exam items, exam questions in. So this is a question you just need to know. What is social justice? And the way that it's defined, you should be able to parse together. There may be several different definitions depending on what you're using as a resource, but you'll always get to this same idea. And as a public health practitioner, these are things that we want to make sure that we know. Social justice, excuse me, it's a breakdown of any barriers that's going to be a barrier to the distribution of resources. Because we want to make sure that we are getting people what they need, and anything that's a barrier in that way, knock those barriers down. That's what social justice is. Health equity is attaining the highest level of health for all. What that means is that everyone has access to health literacy, to doctors, to providers, as much as they can that can speak their language, that look like them, that they can relate to, right? People will need different things to make their doctor's appointments. Some people will need transportation, and if that person needs transportation, we want to make sure that we give them a way to get to their appointment. I may not need transportation for an appointment. I just may need, to get my prescriptions mailed to me so I can get out and get back to work. So that's what they do. They meet us where we're at and they give us what we need. It's not a blanket level of everyone's going to have a certain amount of a resource. No, it's giving people what they need, regardless of where they've come from and what they're going through. And in health disparities, there's going to be a difference in a burden. We often would say a burden, a disease burden, but it doesn't have to be, right? There can be health disparities that are not disease based. And so anytime there's going to be a difference in the burden within a community, within a population, that's going to be a health disparity. All right. And I'm sure we've all seen some version of this. What this is showing is a difference in equality and equity, right? So these words are still being used interchangeably, and they're not. And so having the ability to understand the difference is really going to be key to your ability to have this exam go well because you want to be able to parse out what's going on. So in this example, of equality is everyone has the same box. They're all trying to pick an apple, and the one person that's tall enough, great. The next person, they've got a box, so why can't they get their apple? You gave them all the same thing, so if it works for one person, why doesn't it work for the other person? But when we look at equity, we see that sometimes people need one box, sometimes people may need three boxes, and they may not need any box. Um, there is no monolith for not one, and we should, in order to give people and allow people to be their healthiest selves, we have to be able to give them what they need specifically to them, not just to, or to a population, for example, but not um, a blanket. Everyone now gets access to this one resource because that resource may not be a resource that is useful for every person. So also going to talk about social determinants of health. And these are items, well, they're factors that can impact your health. So this can be things like lack of access to transportation. It could be anything that is has an impact on your overall health due to a social factor or some social aspect. It can be your inability to pay a bill. And so your electricity gets cut off because you can't pay an electricity bill. Now your oxygen tank can't run, right? So these are things that we want to look at as social determinants of health. And it helps to solve really complex matters by breaking them down and addressing them piece by piece by piece so that we don't have to address it all at once. Okay. So the real political declaration is very interesting. The five things that came out of this, which was released in 2011, is that we want to adopt better governance for health and development, right, across the world. We want to make sure that um, what we're focusing on going forward is better governance for health and development. Promoting participation in policy making and implementation, and our membership within the WHO has changed lately, but we can still follow these guidelines. So again, also to orient the health sector towards reducing health inequities. And when we look at health inequities, we think back to a health disparity, which we just spoke about. Um, Strengthen global governance and collaboration, and then to monitor progress and increase accountability. So I'm going to break that down a little bit differently as well, other than just the words, but it's the WHO when they came together in Rio. Um, this reflects a comprehensive public health approach to improving health and reducing disparities across populations. The document serves as a global call to action to focus on good governance to ensure health for everyone. It iterates the government's responsibility to deliver health and to ensure, excuse me, that services are equitably delivered. So again, not delivered in a equal way, but in an equitable way. Responsibility of public health isn't just with the government, though, right? Community participation is crucial for making and implementing anything that we want to do. And we're going to talk a little bit more about this later on with CBPR. We really want to make sure that we're involving the community, that we are um, prioritizing in what we're doing, right? We all have a role to play in ensuring this health equity. All right. So another aspect here is going to be cultural competence. And I want to break this down a little bit more into cultural competence, cultural sensitivity, and cultural humility. These are terms that hopefully we've all have heard. These are things that are very important to us as public health practitioners, but also just as good humans, right? And what this really talks about is before we get into how it's applied directly to uh, health and medicine and those things and how it's gonna go on the exam, we want to make sure that everyone does know kind of what we're talking about here. And so when we look at cultural sensitivity, cultural humility, cultural competence, we want to the big thing for me, and everyone's gonna have their own favorite aspect of it. To me, it's really about the humility, because cultural humility says that I'm going to humble myself to to understand to learn more about the culture of someone else, right? And this can be a community thing. So we don't have to think of it as a major, or I'm going to be interacting with someone from a different race or ethnicity, another class group. No, this can be something as simple as um, my colleague, right? What community am I going into to do a survey, or to hand out pamphlets, or to, do something like that? So going into an area that I'm unfamiliar with, or even I am familiar with, but understanding that I'm coming in from a position of power, and that I need to understand that it's their community, and I need to be able to humble myself, um, and learn from them, right? Being culturally sensitive is also, again, being understanding and sensitive to what we say, what we do, and how it affects communities. And then cultural competence is just a measure of that. And the reason we were using cultural competence here, again, you can be tested on all of these, and you should know all these, but because there can be a direct connection to gauging the competence of a provider, for example, or a health services cultural competence, you can measure those things. But again, so provision of health services is culturally and linguistically appropriate manner, right? And what we try to work on is not just having a translator or have something translated for major languages, or but we want to make sure that we have translators for dialects, for particular, if there's a particular village, if there's a particular tribe, if there's someone that identifies a certain way, we want to be able to do our best to be able to meet that. And particularly if we are in an area where there's a group that have a common language, whether it be Burmese, Spanish, it's Creole. We want to make sure that we can account for those things, that when they call and need help, we can have someone to speak with them in their language, and that is understanding of that. Um, we can also, embody community voice, think about strategies and ways to just always be thinking about the social determinants of health and how we can make things better, how we can use that to engage better within the community, right? And so, as a public health practitioner, and as we're thinking about the exam, you want to make sure that you can identify what cultural competence is, what cultural sensitivity is, what cultural humility is, what role it plays in medicine, what role it plays in um, QI, and across the board, but understanding how we use it and the positive benefits of it, period, as you move forward. All right. Okay. Uh, One of the things I used to love teaching um, about was upstream and downstream effects of things, because I think it's very important for us to understand that things are linked, right? And again, this helps keep us out of our silos. And so, questions like we would ask on the test may not be what is upstream or what is a downstream effect. It may be to define upstream or downstream. This may be where we ask you to use a little bit more application for what you are, the questions or the items that are being asked. So it's important to know what upstream and downstream effects are. Um, and so using just an example here, the upstream intervention, the upstream, the patient, the downstream intervention, right? So before we actually get into this, let's talk about what upstream and downstream is. It comes from the idea that if you're standing with people at the end of a stream, and as you see people coming down the stream, they're all dead. Everyone at the bottom of the stream, as they've come down, is no longer living. And so people are saying, "Oh, well, let's pull them out. Let's make sure that they're not drowning. Let's give them CPR. Let's try to catch them, right before the end. Make sure they haven't hit their head. Let's see what's going on. Let's see if we get them recovered. If we can bring them back. If we can do all these things." But then someone decides, well, let me walk up the water and see what's happening. What's sending them down this way? And then they go up there and they find that there was a safety gate that's missing. And so people are falling over and on their way down. Replace the safety gate, no issues, right? So there is something that leads to something else. The outcome may be DM, diabetes mellitus, diabetes, but an upstream factor of that may be um, sugar consumption, or It may be unhealthy meals or less healthy meals. So there are things, and those upstream things can be because of culture and things like that. And so how do we address those to try to get to the outcome we want, right? Um, and so you can look at this, for example, the example we have here for upstream is going to be health policy, right? So what that top thing, the gate is as opposed to being a safety gate, which is a safety issue, would be a policy idea here, right? And so policy is revised in order to make drugs affordable and accessible because the patient would benefit from a new drug for a chronic illness. And so what's happening at the bottom, the downstream, patient forced to use generic drug, not optimized, downstream intervention, patient pays for drug out of pocket or uses samples. Um, so you look at, okay, you have a person in front of you, in front of your team, they are having an issue because they're having to pay a lot of money out of pocket at the pharmacy, right? So we ask, okay, well, we can give you samples, we can give you a discount card, we can give you a coupon, we can pay for your meds for you, but we really want to know why. What is the issue that's causing this person in front of me who should have their medicine for free, should be covered? Why is it not covered? And you work your way back, right? The person is forced to use a generic drug, um, because even though they would benefit from a new drug, they can't get it for whatever reason. The issue is because of a policy, and a policy which we want to divide it to in order to make drugs affordable and accessible, right? Another example of that would be universal health insurance, would be insurance. So, starting in the middle, again, patient requires imaging for diagnoses. We see the person in front of us, the patient pays or relies on personal insurance for imaging. So again, paying out of pocket. So yourself, why? What is going on? Why is this person paying? This is expensive. Um, a downstream aspect of that could be a delayed diagnosis, um, because the imaging is not done appropriately. It could be done wrong because if you're paying out of pocket, you may not be going to the best imager around, right? Because imaging is expensive. Um, and you still have to deal with this disease and this issue of whatever's happening. And the problem is the health insurance, right? Your health insurance doesn't cover it. They require a prior authorization, and there's a zillion different reasons for that. Uh, and so you get better health insurance, right? So if we had universal health care, then it wouldn't be an issue. Everything would be covered, right? And so that's just how you can look at upstream and downstream effects and how it affects any outcome you have, right? You can look at what's going on, what's in front of you, but you want to trace that back to see what we can stop. What can we do to make sure that this patient never ever has to worry about paying out of pocket for anything? All right. Okay. CBPR, one of my favorite things when I went to UIC for my MPH, I was lucked into a CBPR program that really changed kind of the way my practice works as a public health practitioner. Super community focused, right? And that's what we want. We don't want to be coming into a community and being pushy, right? And there are evidence-based ways to approach communities, to be participatory. And what you want to look at on the exam for this is just being able to, again, identify what CBPR is, understand why it works, how it works, and be able to point out, and we'll go through some of these with the practice questions, but be able to point out kind of differences, how things are like. Um, Two aspects. What we really want for CPR is to improve our interventions, right? Because if I'm using the community to help me figure out what intervention is needed, then I'm winning, right? Then we're doing things the right way. And then strengthening community engagement because the more community is involved, the better it's going to be. The goals are going to be simply enhance community capacity, improve health behaviors, translate research findings. And what that means is giving the information back. You go in and you do a survey, you go back, you take the survey, you do all your data crunching, come back and let them know what you found, right? We report back. If you're going to have them spend the emotional labor to go through the survey, then reward them with letting them know what you found. And these could show up on the test in a number of ways. Some is being able just to identify what some of the key terms is, and some of it could be application. All right, so now we're going to get into some theoretic, some frameworks. We're going to go through a few. We're not going to go through everyone, but it really would be important for you all to get these an idea for these frameworks behind you. Some of us I know these really well. Some of us we've struggled with them, and it's okay, right? That's what studying is all about. Um, so the basic terms of theory, model, theoretical framework, theoretical models, and we'll go over their importance. Theory is defined basically as a systematic way, excuse me, of understanding events, behaviors, and situations. After the model, which is basically a simplified representation of a phenomenon, or in simple words, a visual representation of a thing, right? So after that, we have the theoretical frameworks, which support an existing theory by explaining how a researcher engages with that theory to solve a particular research problem. Lastly, we have the theoretical model, which is a depiction of the relationship between variables within theoretical frameworks. In order for public health programs or interventions to be successful, application of public health theories is important. Our theories and our theoretical frameworks provide great ways to understand and address culturally based issues and the public's perception on some of the issues we've had, right? We think back to COVID, this was a big thing there. And by having this input, this understanding these perceptions, it helps us with understanding and improving health equity overall. There's a lot of frameworks. Again, I mentioned we're not going to go through every single one of them, and no one is better than any other. No one is the framework that dominates public health. They're just all different. They have different reasons, different modes, and different applications. So again, just in the way of definition, a theory is a systematic way of understanding events. Simplified representation of the phenomenon is going to be the model. Theoretical framework is going to be a structure that provides support, excuse me, to a theory of a particular research study, and theoretical model is going to be specific representation of the relationship between variables. Theoretical frameworks address culturally based health issues and public perceptions, right? And again, no one, and we're going to say this again, no one framework is better than any other framework. They all work. Okay. So first we're going to start out with the socio-ecological model. We always say that no one framework dominates, but we often start out with SEM. Well, I don't know. Maybe other people start out differently. I know I typically do here. So socio-ecological model, we've seen this is these concentric circles that kind of build and build and build. And we're going to hit a few of these. We're not going to get all of them. We're going to hit a couple different aspects of this, right? And this is meant to kind of grow as it goes. So first is going to be the individual level, then interpersonal, then organizational, community, and the policy level, right? So this is going to be at each stage. We're going to get a little bit more into this in a second, but typically health promotion prioritizes individual level factors, such as interrogating an individual's knowledge, their beliefs, and their skills for behavior change. Again, this is about behavior change. So, what tools do they already have? But as ecological um, systems thinking became kind of the way that we are doing things now, they've started thinking about other potential ways to help behavior change, right? And one of the early models that came up organizationally was to organize it in this way of a socio ecological model to grow. So the sociological model was developed to understand how the complex and mostly faceted dynamic relationships between the person and their environment, all the environmental factors that are going on, how do those things interact? Okay. All right. So in this individual level, we're going to talk about two theories, trans-theoretical model and the health belief model. And again, we're thinking about these and ideas of behavior change. Okay. All right. And then we're going to go over the theory of planned behavior, social cognitive theories, which are both in that interpersonal um, uh, bubble. And then we're going to talk about Rogers' diffusion of innovations, which is a really neat one. I actually really enjoy kind of utilizing that and thinking about how that works through. All right. So start out with the health belief model developed in the 50s. Um, and it really focuses a lot on risk, right? So what does the individual or community believe about risk and their let's say perceptibility to it? But yeah, right. How much is it relevant to this? Will this affect me? Do I believe that this matters? Right. So some outcomes may be something that may not affect you. On a personal level, as a person, me as a person who was born male, I do not have a cervix. Cervical cancer is not something that I can get. I know about cervical cancer because a lot of people I love and know are susceptible to it, right? But knowing that that's not a risk that I have, I can do things that would bother my cervix if I needed to. Okay. So again, that's kind of where it works, though, right? And the core aspects of it are going to be how susceptible are you to it? Like, is it likely? Actually, I think we're gonna, yeah. Are you at risk for this? Is it something that could possibly happen? And is it serious? Is this the idea that if I go upstairs and go into my son's room, he's gonna hug me? That's a good thing, right? Yay! Is it serious? Yay! I love it. But in other ways, is if I'm not a smoker, how susceptible am I to lung cancer and how serious would it be, right? Think of something like that. Or if I am a smoker, obviously those same things. Then the perceived benefits, right? Would it help? Would it help me to go up and hug my son? Of course it would. Would it help someone to stop smoking? Yes. But what gets in the way of that? Why can people not stop smoking in the moment, right? What are things that can get in the way of that? Maybe it's a stressful job. They smoke when they're stressed at work and or they're at a place where they can only get a break if it's a smoke break. I don't know if those places still exist. That used to be a thing. People would smoke just so that they could take a break or a longer break. And then the next aspect is going to be your cues to action and self efficacy. So, are you ready? Is it time to make this change? What tells me? Is it when I start coughing up? If I'm a smoker and I start coughing really bad, I'm like, okay, that doesn't feel good. Is that it? And can you do it, right? And do I have the ability to stop smoking? Do I have the ability to not do whatever I'm being asked not to do? Can you take this action, right? Because sometimes you may not be able to. Maybe there's a thing, or maybe there's a social reason, a religious reason, any number of reasons why you cannot do something. And so that's something that we have to be aware of if we're trying to institute a behavior change, but we know that this person can't do something because of a religious reason or because of a personal belief reason. So, and so on this, we see the perceived threat. Um, or so again, the health belief model. And then here we have in the very middle, it gives you that what we were just speaking about, the perceived threat. You look at your, severity and susceptibility. then there's the arrow going to the likelihood of the health behavior, right? And so on the other side of this, you see modifying factors, your demographics. There are things that you may be more susceptible to or have a higher severity based on your age or your gender or your economic status. Psychological characteristics, again, your personality, your peer pressure, your family pressuring you to stop smoking or to go back to school, right? These are things that may um, work, right? And these are things that help with that behavior change. And you see how they flow into the threat and then the evaluation of the behavior. Is this something you can do? Is it beneficial? What are the issues and how you can get through those? So that's another way of kind of showing that how this is mapped out. So for the trans theoretical model, which is going to be our next model, um, again, for behavior change, think of this as stages of change, right? So that's the way that it's often thought of. You progress from being unaware to maintaining the healthy behavior, right? Um, when you're thinking about, if you're thinking about smoking, again, tobacco cessation, if someone's an active smoker and they're not thinking about quitting, there comes a point where they may see a commercial, they may have heard about someone getting sick, and they ain't ready yet. And then that's kind of pre-contemplation. Then when they start thinking about it, we're going to move into this a little bit more directly and explain this graph, but it goes through in a way, and you can go. The interesting about the trans theoretical model is that you can go back, right? It's not something where you are just constantly going to something that we need to know as health practitioners is that people can go back and forth between stages. Let's talk a little bit more about that. Okay, so again, the pre-contempl going through those stages, pre-contemplation is no awareness of the problem. Contemplation, yeah, I see that there's a problem exists. Maybe I can do it, right? Maybe I can stop drinking. I may drink a little more than I like to some days, so maybe I'll stop drinking or slow down drinking. Preparation, making small steps towards a change, have the behavior change. Continuation, so it's a thing where you want to make sure you're still, whatever that change is, you're staying active with it, it's continuing to go. And then determine no desire to go back to the unhealthy behavior. But it's important to know that you can sometimes go for maintenance and go back into the contemplation stage, go back into the preparation stage, and that's okay. And then as we see it here, this is written out, kind of showing that pre-contemplation from the very beginning, not really thinking about it. When you start thinking about it, and again, as I mentioned, as you get into step 4, you can go into step 5, or you can go back into pre-contemplation, right? You have to make sure you're maintaining it, and if not, you can go back around, and that's okay. We need to let people know, and let our clients and our patients know that it's we don't want you to relapse to go back, but we can go through the process again, right? It's okay. It works. All right. And I just really like this visualization because it really does show you kind of how it works. All right. And so with the trans theoretical model, another way as you see it written out here, we're going to go through kind of some of the different aspects of it, right? So consciousness raising, when you're increasing awareness about the health issue, you're starting to understand what's triggering, right? So what makes me want to smoke? What makes me want to have that drink? Emotional arousal, it's going to be expressing feelings about the behavior and its consequences. Self-reevaluation is going to be reflecting on one's self-image. So how do you feel yourself in relation to the behavior? Do you see yourself as a smoker or a role model? Do you see yourself as a drinker or a cool uncle, right? Environmental reevaluation is going to be considering how actions are going to impact others in the environment. So, smoking in your car and you have kids, or just any other adult or anyone in the car with you, right? That secondhand smoking, about how that may affect them. Social liberation is going to be recognizing external changes or policies that support the behavior. So you notice now that there are, and I don't know if it's across the U.S. fully, but a lot of places you can't smoke in bars anymore. And that's something that has cut down on smoking. Um, Counter conditioning, so replacing those unhealthy behaviors with healthier alternatives, you know, chewing gum instead of smoking. But again, you want to make sure that that doesn't become a bad habit as well. You don't want to get too much of a sweet tooth, but finding something to kind of substitute that will take away the needed desire for that. And then stimulus control, going to be managing your environment to avoid those things. So, um, not having alcohol or cigarettes at home. You know, bringing a book. So when it's time for your break and everyone else is going to go out and smoke, you read a little bit of a book or listen to a podcast, something like that, right? Having those good helping relationships is going to be seeking and accepting support from others during the change process, and then reinforcement management is rewarding yourself for making progress or for receiving encouragement from others. And now for the social cognitive theory. So this is about acquiring knowledge by observing behavior and results. Something that we can probably, a lot of us, especially if we have kids, can really relate to. There's six basic components, which we're going to get into in a minute. But it's a way of understanding how people learn new behaviors and how they make changes. It presumes that our actions are influenced by a combination of what we think, what we see others do, and our environment. So to think about that little better, a little differently, we learn not just from our personal experiences, but also by watching others and interacting with the world around us. This theory highlights the importance of how role models, rewards, and self-confidence shaping what we do. So, social cognitive theory helps us understand how individuals change their behavior by considering the interactions between themselves and the environment, right? The personal aspects in the environment. This is what we call reciprocal determinism. That's very important. Make sure you write that down. Remember that. It's known as reciprocal determinism. That is basically to say it's behavior that's shaped by your thoughts and your surroundings. So, as an example, if we want to promote physical activity, it's important that we provide supportive environments that have accessible spaces, spaces that are open, uh, that are safe, that are well lit if they're outside. I'm going to do this while also encouraging positive attitudes towards being active. Another key aspect is going to be behavioral capability, which refers to having the necessary knowledge and skills to perform a behavior. When individuals are given information and practical guidance, they're more likely to adopt new habits, such as regular exercise. When we think about observational learning, it's what happens when people see others demonstrating a behavior and are inspired to follow their example. They want to follow that leader. By providing positive role models who engage in physical activities, we can motivate individuals to change their behavior. So having someone that they can relate to, having someone that is um, they can look up to across the spectrum there. Reinforcement is going to be rewards, responses that influence someone. It can be as simple as a good job, way to go. But they can be internal. They can like a sense of accomplishment or external, such as receiving a sense of participation. Expectations are beliefs about the outcomes of a behavior. When you observe role models who experience like exercising and get healthier, and you see that, and it makes you want to take some of the same actions. And it gives those positive things you're seeing will give you positive expectations and encourage others to take those same actions. And then lastly, self-efficacy is having the confidence in your ability to carry out the behavior. So knowing and having the confidence to say, I can work out, I can be active. Building that self efficacy is crucial, it's vital, and it empowers. uh, you, me, everyone to make and sustain those healthy changes. So it makes it stick, right? You have to be able to say, I'm doing it for me. I can do it. It's going to make it stick. All right. And our last theory we're going to focus on today is the theory of planned behavior. This grew out of what would used to be the theory of reasoned actions, which we're going to talk a little bit about how those kind of interact in a moment. But the theory of planned behavior says that behavioral achievement is dependent upon the intention, so your motivation to do something, and your behavioral control. Uh, TPB has six constructs, and we're going to go through each one of them. But it's going to be attitude toward act or the behavior. And that's a belief that a certain behavior or act will make a positive or negative contribution, right? So what do you think is going to happen? Your behavior intention, excuse me, it's going to be your motivational factors that influence a behavior. So the stronger your intention to perform that behavior, the more likely the person will be to do the behavior, right? They have a strong intention, they're more likely to do it. If it's something they really enjoy doing, it's something they're more likely to do. Subjective norms are going to be your factors that the individual, so their social media, their groups, their churches, their workplaces, but factors around that individual and their beliefs as to whether others will approve or disapprove of their behavior, right? If is what I'm doing going to be approved of by my social circle, and whether that social circle be something like a work, a church, or just a friend circle. Social norms is going to be considering, what is normative in a group. The perceived power is the perceived factors or the thought of factors that act as barriers um, or that facilitate to the behavior. And then lastly, the perceived behavioral control is going to be just the person's belief of how easy or hard it is to adopt a certain behavior. So again, is this something that I think I can do? Is this easy? Is this hard? So again, this just gives a few more, a little bit more detail on some of the aspects. Subjective, again, it can be that approval, disapproval, attitude towards behavior is your contribution, that the behavior carries, behavior intervention, motivational factors, approval, disapproval, group norms. That's one that we're really thinking about. Perceived power, factors that facilitate or hinder. Remember, this goes both ways, and then perceived behavioral control. So the theory of planned behavior, it was designed to explain and predict how a behavior is formed. So critical to the model is the behavioral intent and the belief that these intentions are influenced by the likelihood that the behavior will result in an expected outcome. Also, the subjective evaluation of the risk and benefits of the outcome. The theory of planned behavior posits that the behavioral achievement is dependent upon both the intention, your motivation, and behavior control. Also, um, so we've used this in the past to predict health behaviors, including substance use, breastfeeding, health service utilization. We use this to model out and think about things like that. But it's not without its limitations. It doesn't account for environmental factors. It doesn't account for economic influences. It talks a lot about group, but it doesn't give some of the things that can affect different aspects of it. And those things are super important in adopting a health behavior. Right, so here's a virtual representation of the theory of planned behavior. And we're going to see how these constructs can be utilized by healthcare providers, by us professionals, to understand the behavior of someone that wants to quit smoking. So again, we're using the smoke cessation. It's a great tool to use for this because I think a lot of people can relate to how we do these steps. So first thing that we're going to do is going to be the attitude, which in this case would be a positive one towards quitting smoking, right? The person wants to quit, so that's a positive attitude. The subjective norm is going to be the case. in this case would be a smoker thinking that quitting will result in their family and friends being more accepting, right? They don't kick him out to go smoke because he smells like cigarettes. Um, the behavior control is going to be the smoker recognizes that there are barriers that may come in the way of quitting, but he has the ability to overcome them, especially with his group and with his people with him. As you can see in the diagram, these constructs influence smokers' intention to quit. Uh, Further influencing their behavior might range from smoking less, not smoking at all. You start using, gum, patches, or something of that nature. Okay, I think I might have said the last one was the last, but maybe the last of that title size. But now we're on our really our on our final model. It's going to be diffusion of innovations. And what it is an innovation is going to gain popularity and spread throughout the population, right? When it comes to public health, the process of adopting a new behavior takes time, since some people may be less likely to make that change than others. We have five adopter categories that are used in this theory. It's going to be innovators, early adopters, early majority, late majority, and laggards. Innovators are going to be those individuals who adopt the behavior right away, sometimes even before, and are basically the first ones to take up on it. Early adopters are going to be the next group. They're going to be leaders who understand the importance of change and are willing to contribute to it, right? And so they're going to kind of come on early, and then that influences others. Then the early majority are going to be those individuals who adopt the new ideas earlier than the rest of the people. The late majority are going to be those on the other end that are a little bit skeptical at first, but then kind of pick up on it. And then the laggards are going to be the people who remain skeptical of new ideas. And the next slide, I'm going to go over this a little bit more visually. All right, so we look at this graph. This will give us an idea of kind of how something is brought up and kind of the path that goes there. So the idea, the product, the process, right? So when we see something happening, we see that people that are innovators are going to be doing it early, and then as it gains, it gets to the point where it starts to go down, um, and pick up on the other side, right? And we can think about this, and think about cell phones or computers, or I still have an aunt that has a flip phone. I think we would call her a laggard, and that's okay because she's fine. She's doing great. I'm a little jealous sometimes. I wish I could just have a flip phone. Um, but yeah, but this kind of just shows that timeline. So want to make sure you understand two terms, particularly going to be diffusion and dissemination. So diffusion being the process by which innovation is communicated through channels over time among the members of a social system. So behavior changes as the innovators are adopted or the innovations are adopted, right? So the behavior change in this is when you have your innovators and early adopters and they start bringing more people in and you start to see that curve go up. That's the behavior change. Then dissemination is going to be if you've planned so a planned, systematic effort designed to make the program or innovation more widely available to a target audience or members. So this is when you start to you disseminate it, right? You say, oh, this works, so we're gonna put it in this community. We have here in Chicago, we have public health vending machines, right? Once we got them working, we try to get them out to more and more places. But again, you think about this as cell phones, computers, even new electronic health records. Sometimes we're seeing kind of on the same curve. All right, so that was a lot. Really appreciate you all listening and seeing. We're going to get ready to go into some questions. This would be a point where if I had 10, we'd be able to ask questions and I would be able to give you a few tips. So I do want to do that. I do want to say some exam tips that I have before we move into the practice questions. Um, is that this. If you're going through these classes and you're sitting through these review sessions, you got it. I took it, I was very scared. I passed. I didn't get them all right. I didn't get them all wrong. Um, and I want you to know that we write questions. So again, I've been an item writer. We write these questions in a way that is, we're not trying to fool you. We want you to join our ranks of CPHs. Um, so don't think that we're trying to trick you. We don't do that. We write questions in a very specific way, um, and in a way that is clear and defined. A lot of times you should look, there'll be references that you can use that may be helpful if you have a question about something. Um, but yeah, good luck. Take your time. It is definitely worth it. And you know more than you think you know. Using the resources you've had, the review books, these review sessions, I really think that if you've come to these, you will be ready. All right. So let's practice. So we're going to go through a few, I think maybe 40 questions. What I'll do is I will show you the question. And what I'll do is, even though no one is with me, I'll give it a count of five, but you should also be able to pause this if needed. And then we'll go on to the next slide with the answers. I will interject some on the answers to give like some thoughts about how to choose the best answer. If there's multiple things like that, or if something isn't clear, I'll try to anticipate and explain that for you. Again, all the questions are going to be multiple choice. They're always going to have four options. There will never be a all of the above, none of the above. Um, yeah, so there's some things you don't have to worry about. We're not trying to get you to do that and then have an issue with not only recognizing three of the four. So that's not what we're trying to do here. All right. So our first question. All right, variation in rates of medical procedures by race even when controlling for insurance status, income, age, and severity of conditions is an example of what? All right. Um, Health disparity is what it would be. Health disparity. I think we knew that. Starting out easy, you should know that. A good way to do this, if you're looking at this, is to think of, okay, there's four options here. Is there a throwaway? Is there an answer that we know 100% is incorrect? Uh, we know that inadequate access to healthcare, high rate of uninsured individuals, racism, health disparity. But this is asking about a variation in rates of medical procedures by race. So racism is part of that, but it's a health disparity. So maybe you throw out racism right away because it doesn't fit the question. And then they get inadequate access to healthcare. It could be, but this is again, it's a definition. It's something that you have to know that's what it is to identify. All right. Okay. Which practice enhances equity across populations when making health policy decisions in a community? All right. Including diverse constituencies in the decision-making groups. So, allocating resources based simply on population size may not target resources to the most needy populations or issues in the community, nor will it guarantee an improvement in equity. Uh, C is according to size, not according to equity. And collecting data is important and can be useful in policy process. However, collecting data alone without interpreting the data and having a diversity of stakeholders weigh in on the results will be used to make health policy decisions that impact the community will not enhance equity. All right. All right. Which of the following is a characteristic of a healthcare system based on social justice? So, which of the following is a characteristic of a healthcare system that is based on social justice? All right. And the answer is an individual's ability to pay is considered inconsequential for receiving medical care. Social justice is established by the fact that an individual should receive medical care whether they can pay for it or not. Other choices do not really fit in the category of defining social justice. All right. The demonstration of flexibility, openness, and self-reflection so that cultural learning is possible when working in community partnerships describes which of these? All right, cultural competency. Just another definition term, cultural competency, which is also defined as the ability to understand and respect people's values, attitudes, beliefs, and that may vary across cultures. All right. Which approach is recommended for analyzing the accessibility of public health services across diverse populations? All right, conducting community-based participatory research. So, analyzing the accessibility of public health services across diverse populations often involves conducting CBPR to understand the community's needs and their preferences. All right, and analyzing the availability of public health services across diverse populations, what significant role does community engagement play? It helps gather local perspectives and identify gaps in services. What is the term for the biological, environmental, behavioral, organizational, political, and social factors that contribute to the health status of individuals, groups, and communities? Right? The determinants of health. Right? So we read about the social determinants of health, all biological, environmental, behavioral, organizational, political, social factors that contribute to the health status of people, groups, individuals, communities, and beyond, all referred to as determinants of health. All right. A public health worker is charged with investigating family violence in a community of nearly 1 million residents. The worker uses principles of systems theory in their approach. They incorporate individuals, groups, and their environments. Which of the following terms best describes this concept? All right, social ecology. So this is another one where you would want to maybe break down what doesn't fit right away. If you're investigating family violence, there's probably nothing in ethnobiology that, that would help, right? Um, Community psychology, yeah, maybe. You can look at that from an idea, but because the community, because what we're doing is going to be social ecology. As you may remember, the social, this is, sorry, this socio-ecological model goes over different levels of influence. In this question, the term individuals groups, and environments gives us the idea that this was asking about the concept of social ecology. Um, and we didn't really go over the rest of the concept, so should make this a little bit easier. But for the exam, that's kind of what you want to think about. All right, which of the following terms from the social cognitive theory refers to the dynamic interaction among the person, environment, and behavior? All right, reciprocal determinism or reciprocal causation comes from the social cognitive theory, refers to the inner relationship between a person, their environment, and their behavior. All right, which of the following is the best example of interpersonal factors that affect an individual's behavior as outlined by the social ecological model? Personal knowledge or skills. So, interpersonal factors are defined as characteristics of the individual, such as knowledge, attitudes, self concept, and skills. Informal social networks would be defined as interpersonal factors. Um, all right. Okay. Which of the following do social cognitive theory and the socio-ecological model have in common? Both consider factors that are within the individual and factors that are operate outside the individual. Social cognitive theory and sociological model to the factors that are within the individual and factors that operate outside of the individual, so the social and physical environments. Option B is true for socio-ecological model, whereas option C is true for social cognitive theory. And D is for neither. So this is one where you could have looked at it and say, okay, well, D doesn't count, so you can throw that away, leaves you with three, and then you can kind of figure out which is which has both, which has one, and that would be a good way to break down this question. And that's a good exam skill to have is being able to throw one out, see what's most likely, and be able to work through that. All right. Which of the following models explains the relationship between socioeconomic status and health by illustrating that health status and social standing are linked to a combination of interrelated social, cultural, psychological, and environmental factors? Okay, so you have the four options on there. I'll also say this is a wordier question than we would ask now. We would find a way to make this a lot smaller or just not ask it. There are going to be questions that have several lines of text, but not that many. We really try to keep it as concise as possible. So again, that's one of the reasons you see some of these questions here. These are questions that were retired or have already gone through a few times, but yeah, not that this is super long, but you will definitely find some that are this will be kind of on the longer side if that's really uh, probably shorter than this actually. Right, so it's gonna be a socio-ecological model. This is the basic concept of the socio-ecological model and can also be demonstrated visually. Trans-theoretical model is the model of stages of change and theory of reason action is the original form of the theory of planned behavior, right? And both these models don't really explain the relationships that are asked about in the question. Right, which of the following is not a construct from the health belief model? Um, So, which of the following is not a construct from the health belief model? So, we think about the health belief model is what it does. Which of these does not fit within that? There's going to be decisional balance, right? So, this is just purely recall. Definitions, identifying things is purely recall. You have to know the steps, those constructs within each of those models, particularly the ones we went over. Right. Which of the following processes from the trans theoretical model refers to substituting healthy behaviors for unhealthy ones? Right. Counter conditioning. So within the trans theoretical model, stage movement is accompanied by one or more processes of change. Counter conditioning, substituting healthy behaviors for unhealthy ones, is active during action and maintenance. All right, I believe this is our last question. So, for individuals who recently stopped misusing alcohol, it would be best to avoid people, places, and things that may serve as a trigger to drink. According to the trans theoretical model, this process of change is what? So, for individuals who recently stopped misusing alcohol, maybe they're in treatment, it would be best to avoid people, places, and things, nouns that serve as a trigger for that. According to the trans theoretical model, this process of change is stimulus control. So just like in the question before, same thing can be said here that stage movement is accompanied by one or more processes of change. And in this scenario, all the things that may hinder an individual from alcohol misuse serve as stimulus, and avoiding such a stimulus would be the right thing to do here. And that's what stimulus control. So that would be the control for it. All right. So best of luck to you all. Again, I wish I was with you in person. But maybe I'll see you in another class. But it's a great challenge. Study, be ready, trust yourself, right? If you do the work, you put in the time it needs to do it, you'll be fine. You'll be fine. Test isn't we're not trying to fool you. We're not trying to trick you. We're not trying to make it super easy. It's not an easy exam, but it's an exam that is worth your study. And I look forward to calling you all fellow CPHs soon. Thank you so much for your time.